We could probably get, yeah, I think we can probably get started. I know a few more people will trickle in, but welcome everyone to Geriatric Medicine Grand Rounds. We're so glad you can join us. I hope you're all enjoying breathing fresh air that has arrived. It's been long awaited. I'm really appreciative to our speaker today. Many of you know her, Dr. Lucy Wang, who's based at the Puget Sound, Seattle VA here. She's an assistant professor in the Department of Psychiatry and Behavioral Sciences, is the program director for the Geriatric Psychiatry Fellowship Program. So I've appreciated her collaboration over the years. And many of you interact with her on the clinical side, and she has her clinic over at the VA. So I'm very appreciative that you're coming to speak with us, Dr. Wang, about the geriatric mental health workforce, which is even in greater scarcity than the geriatric medicine workforce, which is, has a shortage. So thank you for sharing this information with us and for taking the time to join us. And I'm eager to hear what you have to say.
Thank you, and absolutely thrilled to be able to talk with you all today about this. And just so you know, I am wearing my Geriatric Psychiatry Fellowship Director hat in terms of my interest in this topic, in terms of getting more people interested in geriatrics and geriatric psychiatry in particular, and also kind of wanting to see or know what movements are being made to help get more people interested, not just locally or personally, but in larger contexts. So that was the background or foundation for me building up this talk. I am going to say up front, I'm going to mention programs or initiatives that chances are some of you in the audience know better than I. So I do have my chat box open. Feel free to add stuff in the chat if there are things that you would like to add or clarify, or even just sort of maybe at the end clarify your role in some of these initiatives and programs, because we got some exciting stuff happening amongst our departments here. So let's go ahead and get moving. So the outline of the talk, I'm going to divide in 3 sections. The first, I'm just going to introduce who the geriatric mental health workforce people are. The second section, I'll just describe some concerns and trends with, I'm going to admit, a slight focus on geriatric psychiatry, because that's where I come from. And then lastly, what are some ways that we can help both on an individual basis, but also if we want to move forward and help or support larger systems or kind of public health focused initiatives. So that's the top or the outline of our discussion today. So the first category section, who are the geriatric mental health workforce? I think I'll introduce this by just asking to think about, what are some mental health issues that are unique to older adults that you've encountered in your practice? That will give you a clue on, who we are, what we do. Okay, so we're not just the psychiatrists, we're psychologists and other professionals. I'm going to just introduce maybe a few cases or scenarios that will kind of maybe ground you in kind of what we can do. For example, let's say you have a patient with depression. They also have mild degree of cognitive impairment. If you refer them to psychotherapy, what could that psychotherapy look like? Specialists in geriatrics in the mental health field will be able to know how to modify psychotherapy for cognitive impairment, whether incorporate caregivers. You will also know when potentially the psychotherapy is less productive because of problems of carryover, and switch over to different modalities, whether it be caregiver education support or changes in the environment. Another place where a geriatric mental health provider is, uniquely, sort of trained and able to assist is sort of suicide risk assessments in sort of complex situations. I know you've encountered this, where, for example, you have a patient with a lot of risk factors for suicide: widowed, socially isolated, multiple medical comorbidities, maybe own a firearm. They may talk to you theoretically that if they became disabled, they would want to kill themselves because they don't want to be a burden on others. How do you do that risk assessment in this kind of scenario where you're weighing risk factors, but also end-of-life considerations, values, goals, and a geriatric mental health provider? It could be quite comfortable and uniquely sort of trained to be able to help manage that. I also have seen lots of gaps in systems, and I feel like those of us in geriatric, mental health, but geriatrics in general, as we can influence sort of where we work can hopefully improve the care of older adults that are falling in these gaps. My specific example is a patient of mine who has Parkinson's disease. And when I first met him, literally the week prior, he was having behavioral symptoms that was, a complication of Parkinson's disease that included hallucinations, dysregulated behaviors, even self-harm behaviors. His wife took him to a local emergency room, and they said, we can't help you. So this hospital didn't have the environment, didn't have the staff, didn't have the specialists that they felt they needed to be able to care for this patient. So they ended up sending him home. So that really kind of hit hard, that someone who was suffering and at significant risk, there was a whole hospital system that said, we don't have the space, the people, the resources to help you. So those are some examples that I hope can clarify for you a bit on kind of what geriatric mental health providers can serve, what gap we can fit in and help improve the quality of lives and decrease suffering in our patients who are older adults. So stepping now into sort of more details, I just go through a list of different mental health or just general providers that are involved in mental health care in older adults. And I'm going to start with geriatric psychiatry, of course, again, which I said is my bias as the program director here. First, what is geriatric psychiatry? We are defined, at least by the ABPN, as our American Board of Psychiatry and Neurology, as a branch of medicine in the subspecialty of psychiatry dealing with the study, prevention, and treatment of mental health disorders in older adults. We've been around for a little while. The first certification examination in geriatric psychiatry was administered by the American Board of Psychiatry and Neurology back in 1991. And since then, so as of the December 2021 numbers, there have been 3,638 initial certifications. So we've had, over 3,600 people become geriatric psychiatrists since this field was recognized by the certification was recognized by the ABPN. I'm going to move on to sort of recruitment numbers here on the next slide. There were over 3,000 kind of over the lifetime of this sort of specialty as recognized since 1991. This is from the APA resident census, giving us a sense of how many people are coming out of these fellowship programs on an annual basis and more recent trends. So this is a busy slide. I'll try to walk you through it. What this summarizes is different specialties or subspecialties in psychiatry, specifically the fellowship programs, and how many people are enrolled, so to speak, or matched, or I guess in these programs at any particular year. So for example, I'll highlight 2017. I'll take the little pointer out here. There's a pointer. So 2017, for example, addictions, they had 74 fellows nationwide in addictions programs. Child and adolescent is a little bit misleading because child and adolescent fellowships are 2 years. So you can consider it maybe 400, 500 people per class. If you look at geriatrics, we are the lowest in number out of the different subspecialties in psychiatry. We graduated, I don't know, but we had 33 people in 2017 nationwide in geriatric psychiatry fellowship programs. And this is just a sort of a visual breakdown of what that looks like. So here we are in the 50s. Some more numbers to help you kind of figure out the trend. This is fill rates. So again, let's pick 2018. There's a pointer. We had, it's like 55 spaces or positions filled. We actually can have as many as 157 nationwide. So we are filling back at least in 2018 at a 35% fill rate. So I think the other specialties are not that much better. Addictions, consults, forensics, with the exception of child adolescent, they're closer to 80%. Kate, I know you probably know this better than me. I want to include all of you as also team members in geriatric mental health. Sometimes people in psychiatry ask me, how's geriatric medicine doing? I pulled this from the NRMP match data report in 2021. Thanks for the comment there, Mary. And so in geriatric medicine, I feel like you're doing better than us in psychiatry, but still lots of space for you all to get more colleagues. So here, 2022. So this is the little green positions filled, 210 compared to positions offered, 411. So we can all use more of all of us. All right, so far I've listened to geriatric psychiatry and sort of our trends. Geriatric medicine, I consider you all teammates in the geriatric mental health team. I'm going to start listing a few other people to introduce you all to who I consider geriatric mental health providers. So geropsychology, this is a field within psychology. So this is according to the American Psychological Association's website, the field within psychology that applies the knowledge and methods of psychology to understanding and helping older persons and their families maintain well-being, overcome problems, and achieve maximum potential during later life. This specialty started in 2010, and in 2014, the American Board of Professional Psychology added geropsychology as a boarded specialty. I had trouble finding numbers in terms of kind of enrollment or kind of graduation rates. Just a quick glance at the American Board of Geropsychology's website, however, listed less than 100 individuals as certified. So I don't know if that's up to date, but if you're thinking nationwide, the sort of the primary website listing individuals with that specialty less than 100, it's a rare and kind of uncommon sort of breed of individual that are geropsychologists. But I'm privileged to have had an opportunity to work with a few, and I hope that we get more colleagues in this field as time goes on. Has there ever been ACTV discussion about a 2-year fellowship from family medicine, internal medicine, geriatrics, and modified geropsych? I realize that geropsych needs to follow psych residency. Yeah, I think that as currently sort of, how do I want to put this, sort of constructed or formulated, the idea for this particular subspecialty is they have to be a psychiatrist first. And the fellowship programs, as they're currently structured, are kind of built on that foundation. But I do appreciate that you all or primary care is probably doing the bulk of mental health out there. So if there could be some way to recognize some kind of additional training or some kind of additional, recognition, official recognition of someone with a different sort of foundational training and residency, having more experience in geropsych care and needs. I can certainly see that. But there has not been, to my knowledge, a discussion on that, at least on the psychiatry side, probably for a number of reasons. But I agree, I feel like there could be some way to better leverage our expertise and workforce or meeting needs by being creative about what training can look like. Moving on to list other sort of colleagues, the advanced practice nurse practitioners. My understanding is there used to be, so in 2013, the certification for gerontology for nurse practitioners was phased out and combined with adult care certifications, which in a lot of ways makes sense. So you have fewer of those people recognized as maybe specialists in gerontology, but my understanding is that the curricula and sort of the general adult certifications were really bulked up with regards to geriatric training, so that all nurse practitioners should meet a certain kind of high quality minimum in gerontology or geriatrics knowledge and care. Physician's assistants, my understanding is that there are no added qualifications in geriatrics, but I did find geriatrics residencies exist. I'm happy to hear if there are updates or corrections to that. Registered nurses certified in gerontology. So the American Nurses Credentialing Center does offer a gerontological nursing certification, so that can be available. My understanding is that those numbers of people who are nurses who do choose to move forward with the certification are still relatively low. I found an old number back in 2014 where they said, where I found 7,874 nurses certified in this out of, that's about 3.1 million nurses nationwide. There are board certified geriatric Pharmacists, according to the Board of Pharmacy Specialties website, there are currently more than 4,700 board certified geriatric pharmacists out there as well. Social work, there are additional sort of qualifications or credentials that you can get if you choose to, including a social worker in gerontology or the clinical social worker in gerontology, and then third is the advanced social worker in gerontology. So with different sort of requirements for those credentials if people choose to pursue them. I didn't know this, but there are also board certified clinical specialists in geriatric physical therapy and gerontology certified occupational therapists as well. So again, I know that many might not necessarily consider themselves specifically as, it's like, mental health, but I consider you all team members because we are multidisciplinary. We work as multidisciplinary teams, and the mental health of my patients often rely on the care of all of you and all of these people. These disciplines are listed, as I gave a reference there, as an area of growth and focus for helping people who are older adults with mental illness. The last but not least, I'll mention are the direct care workers, nursing assistants, home health aides, home care aides, personal care attendants. Again, vitally important in people who are providing day-to-day hands-on care. Really important for, again, mental health. So implementation of some of the mental health behavioral recommendations that we may make. They provide the daily contact for patients, and I do consider team members when I work with them and patients, like I'm sure all you all. Thank you, Barbara. There is a certificate program in geriatric pharmacy here at UW. That's fantastic. Okay, what about community-based mental health MHPs? Any gero-focused training available for them? May I ask what you, maybe in the chat, who you were talking about in terms of mental health priorities, if you're talking about sort of maybe therapists, counselors, things along those, kind of that type of provider, or feel free to just clarify that question. I'm happy to try my best to answer. Direct care workers, you know better than I do, I suspect, about the challenges with, direct care workers, the training that may or may not receive, especially for dementia care, high turnover rates, slow compensation, challenging work environments. So there are significant vulnerabilities to the stability of this workforce as well. Okay. So that is an overview of team members who are mental health. I consider mental health, my mental health team members. I'm going to move on to the second section of my discussion today, which is concerning trends. If none of you have seen this, I like to share it because I like to share it with all my trainees as well, because I think people forget, it's nice to have this visual about the trends in our populations these days. So the United Census Bureau has this graphic available, and the title is An Aging Nation. And the sort of subtitle there is, for the first time in U.S. history, older adults are projected to outnumber children by 2035. And you have a nice graph there, both in terms of a line directionality graph and also a bar graph that tells you, hey, in 2035, yes, older adults and adults over the age of 65 are going to start exceeding the number of children under age 18. I feel like our society does, for any number of good reasons, focus on care for children. We don't have enough child psychiatrists, for example. I think that's a really important need, but that does not negate the fact that our older adult populations have significant need as well, and that population is going to exceed that of our younger people, not in too far in the future. So we're talking, what, 13 years. So for trainees, when I talk to medical students and residents, they're going to be in the height of their practice during this period. So they're going to see the shifts in their practice, and it's important to train them and help them get resourced to be able to meet this important need or shift in needs within their career. Some other interesting information I came across. There was analysis of findings from the 2021 Commonwealth Fund International Health Policy Survey of Older Adults, and it's titled Comparing Older Adults' Mental Health Needs and Access to Treatment in the US and Other High-Income Countries. This survey included more than 18,000 adults aged 65 and older in 11 high-income countries. A lot of interesting stuff in here. I wanted to highlight that more older adults, U.S. older adults, more U.S. older adults sought after and received mental health care in other countries. So kind of access was actually pretty decent. And about 1 in 5 older adults did identify as having a mental health diagnosis. So, and it was reassuring that in the US, comparable to other nations, that access in a lot of ways was comparable, but they did discuss some barriers. So 26% of US older adults said that they had limited access to mental health care because of cost. So the researchers in this study elaborated that despite Medicare and the protections it offers, many older adults, 26%, said that costs did cause some problems with access for them. And the next highest was 14% of older adults in Switzerland reporting costs related barriers to mental health care. So the 26%, the next one down being just 14% in Switzerland. I also want to highlight that while not a specific question in this survey, the authors of this work did mention that the number of psychiatrists accepting Medicare, as well as other insurance in general, has declined over time. So there's no guarantee that in-network mental health providers are available for older adults, particularly those relying on Medicare. And that's been my anecdotal sort of experience as well, talking to people in the field, that for psychiatry, it is still feasible to have a practice without billing insurance or Medicare, and that limits access to older adults where they rely on those insurances to be able to pay for care rather than private pay. Okay, so I just mentioned so in this slide, I'm mentioning sort of access issues. In this one, I wanted to highlight sort of, again, the needs from a population standpoint. So this was published, it's older, so it's based on the President's Commission on Mental Health. So the President's Commission on Mental Health Subcommittee on older adults. This is back in 2003. And they used an estimate of assuming 80 new geriatric psychiatrists per year. And as you know from a few slides back, we're actually graduating more like 50 new geriatric psychiatrists a year. So this, again, is older, but assuming 80 new geriatric psychiatrists a year, this subcommittee, or this commission for the subcommittee, estimated that by 2030, so approximately there would be 2,648 sort of actively practicing geriatric psychiatrists by year 2030, because they're assuming a 3% attrition of people retiring over time. So 2,640 geriatric psychiatrists will be around 2030, but their calculations are that you really need 4,000 to 500 practicing geriatric psychiatrists to meet the population needs or mental health needs for the older adult population. In addition to the 4,500 that they estimated as being needed, 1,200 or 1,220 physician, faculty, and I don't know where the 919 came from, but 919 non-physician faculty would be needed to continue training and continue the pipeline. 2,640, which is the estimate, is far lower than the estimated need of maybe 6,000. I'm going to keep talking about this kind of scary trend by reminding you of Alzheimer's disease in particular as a growing concern. I think that geriatric psychiatrists or geriatric mental health providers in general are really well poised and tend to take ownership for the mental health needs for patients with cognitive disorders, including dementia. So not only is the number of older adults growing, number of people with severe or neurodegenerative disorders growing. I think another reason I'm going to highlight this particular slide is that, that estimate of geriatric psychiatrists, how many are needed. I think some people could argue that, and just because you're an older adult with a mental health need doesn't mean you actually need to have a geriatric psychiatrist. That general psychiatrist can provide just as good care. Really good primary care providers can provide really great care. So do we really need the 4,000 to 5,000 geriatric psychiatrists that was articulated in that previous slide? So what I'm doing here is saying now moving forward to what if we focus the need to just to that population that is probably mostly kind of really where, for example, geriatric psychiatry really can, that is our ownership. This is what we focus on, that we are probably one of the best able to handle behavioral disturbances associated with Alzheimer's disease or other dementias. So anyway, back to this slide, reminding everyone of the growing number of people with Alzheimer's disease. I like to, remind everyone that, we're gonna, let's see, 2020, we got 6.1 million people with Alzheimer's disease. Let's say in 20 years, we're close to doubling the number. So, I like to tell the residents I work with, you see the number of older adults in the ER who are in the hospital when you're doing your rotations and sort of the challenges that they're meeting in that setting. Think about double that. Double that within your career within 20 years, and picturing that challenge. Okay, so mental health. MHP previously used Washington State Referral Licensed Mental Health Counselor. Got it. That's a good question. I actually don't know. So you've asked me a question I don't know the answer to. So if anyone does, feel free to chime in. And another quick sort of complicating factor is kind of the need for culturally sensitive or sort of race sort of disproportionate sort of access and care and diagnoses according to race, and how that even just getting enough mental health providers is tough, but potentially finding a culturally sensitive mental health providers for older adults is going to be even harder. But I did want to throw this slide out there to remind people that the dementia incidence rates do differ by race and ethnicity. African American seem to, so let's see here. So older Black and Hispanic Americans seem to be disproportionately more than white Americans have Alzheimer's disease or other dementias. And the last one, kind of lowest reported, would be for Asian Americans. And it's thought to be that higher risk, health related, so higher risk medical conditions, health related behaviors, socioeconomic risk factors likely contribute to this difference. Okay, so if we're looking at older adults, let's pare it down to just Alzheimer's disease patients needing sort of even cultural sensitivities because of some of the challenges or particular challenges that different groups have, and then honing in on those that have behavioral and psychological symptoms. Just a reminder that behavioral psychological symptoms can span any type of symptom because we're looking at some global brain damage. And I list this is a neuropsychiatric inventory of the 12 subcategories, just to give you a sense of what it is that we might be looking at. Include delusions, hallucinations, agitation, aggression, depression, anxiety. Elation, euphoria is on the list, although I'll confess I don't think I've seen that in my patients. Apathy, indifference, disinhibition, irritability, lability, motor disturbance, nighttime behaviors, appetite, eating. So just a sense of what behavioral disturbances could look like. Again, the reason I bring that up is if we're looking at geriatric psychiatrists, we're the ones who probably have the most ownership of those behavioral psychological symptoms in dementia. What if we take every geriatric psychiatrist and only have them see this specific tiny slice of the geriatric population, this tiny slice of what our field does? So 2030 in that Alzheimer's Association slide, so this is my napkin calculation, back of a napkin calculation, 8.5 million people with Alzheimer's dementia. I forgot to mention previous slide that prevalence studies estimate one sort of review article giving a prevalence estimate, estimated 60% of having patients with Alzheimer's dementia having agitation. So if you do that, that's about 5 million. We took that prior estimate a few slides back where they estimated in 2030 having 2,640 geriatric psychiatrists in practice. That would mean that of those, you would have only one geriatric psychiatrist for every 2,000 patients who have Alzheimer's disease-related dementia, dementia-related agitation. I'm sorry, Alzheimer's disease or dementia-related agitation. So again, taking like just this very tiny slice of one particular problem, we still don't have enough geriatric psychiatrists for that one particular problem, which is dementia-related agitation. Agitation feels high to me. It is, so as a prevalence, you're right. I did pull out a little bit out of blue because the different studies will differ depending on the setting. You know, it's relatively high in nursing home settings, a little less in the community. So I'll grant you that. I'll grant you that. That it will be different depending on where you look. Let me go back to my prior slide. I did have some notes on that. Yeah, it was a study. Yeah, so one study, the Cache County study, this is not a prevalence rate, but kind of a lifetime incidence or lifetime occurrence. 97% of individuals will just experience some type of behavioral psychological symptom. And the study I cited, I didn't make notes as to which one it is, so I'll have to get back to you on that. 80,000 patients, 24.6%. I'm sorry, 78,000 patients, 24.6% of those had Alzheimer's disease, and of those, agitation occurred 61.3% after the study. I can get back to you about what that study is if you're interested. All right. So I just went ahead and basically just scared myself and everyone about how there is no way that there's enough geriatric psychiatrists to meet the needs even from our sickest patients. We're not the only ones in crisis. I thought I'd just highlight a couple of these headlines that you've seen as well to remind everyone that on the other team members, so the other mental health team member that's in dire straits are our direct care workers, long-term care facilities. I found this headline back in February when the COVID surge was still kind of working its way. Every bed is full. UW Medicine Warren's hospitals still at capacity despite falling COVID cases. Dr. John Lynch with Harborview Medical Center is reminding everyone that hospitals are still feeling the extreme burden created by the pandemic, and down kind of the first paragraph, while mask mandates and COVID vaccine requirements are seemingly being dropped left and right, the UW Medicine Hospital has warned that capacity remains virtually maxed out across all 4 of its campuses. This was in large part related to the difficulty getting patients in the hospital and those backlogs of patients into long-term care facilities. So they're really maxing out all the beds. This has not gotten better. As your Harborview told me that this is still a huge problem. This is the Seattle Times article back in September, just about a month ago. Harborview still way over capacity as long-term care shortage persists. Harborview Medical Center continues to care for nearly 100 more inpatients than its licensed capacity as it struggles to discharge patients who no longer need hospitalization, but still need significant care and have nowhere to go, the hospital CEO said Wednesday. So anyway, I just decided to take those couple of slides again to highlight another concerning trend for another group of care providers, and specifically in long-term care. Okay. So that was my section on disturbing trends in the mental health workforce. So anyway, I just made that argument of 2 types of workers being in sort of dire straits. What can we do to help, both on sort of an individual basis and potentially supporting larger initiatives? I like to just start with what we personally can do. This is where I get a bit on my soapbox, and I know you're on the same soapbox as me, and that is that I do worry that ageism influences how people decide potentially to go into geriatrics as a field. I got this slide courtesy of one of my geropsychology colleagues, so I want to give her some plug, Hallie Newsom here at the VA. So ageism is stereotyping of or discrimination against an individual or group based on age. I think for providers, I just think, but there's some work demonstrating that ageism for providers can lead to challenging outcomes. So more likely to view a negative outcome as a natural consequence of old age rather than something that we can help or improve. More pessimistic toward outcome of intervention, so potentially can lead to not offering certain interventions, perceive more challenges working with older adults as opposed to opportunities, and maybe less likely to intervene or suggest intervention. So ageism providers is a problem. Also, just sort of how we interact with our older adults. Ageism can come out as well-meaning but patronizing treatment of older adults. For example, elder speak, so that our older adult patients don't feel heard or aren't cared for. Thanks, Angela. I see your chat there. Have a good time in clinic. So just a reminder that this exists and can cause challenges, and that we can try to help medical students and residents, see what ageism is, and help. Let's all sort of do our best to kind of raise awareness, combat that. Even in sort of our publications in speech, I pulled this out of the APA publication manual, their bias-free language guidelines, and just to avoid problematic language in our presentations or publications. These include the elderlies, elderly people, the aged, aging, dependent, senior citizens, senility and senile. Other options you can put in your sort of teaching include older adults, older people, person 65 years and older, the older population, person with dementia due to Alzheimer's disease. Again, we're moving away here from describing people as a disease. Way back when we would say, instead of like schizophrenic, we now say some person with schizophrenia. Someone is not defined by disease, or a person with a disease. So if you're diabetic, you're not, it's like diabetic, or a person has diabetes, you're not defined by your disease. So it's sort of the same concept. All right, so what we can do: recognize ageism, teach about it, recognize our own language. I also try to pass on to my trainees to kind of, when they see an older adult in their room, maybe they have cognitive impairment, maybe they're delirious, they feel less like a person sometimes, I feel like. And I want to remind people that our older adult patients come into the room with a wealth of experience and a wealth of, they live through some paradigm shifting eras. So one thought exercise that you can have for yourself or with trainees that we work with are, think about what are some sociocultural changes that occurred in the US in the past 100 years, because our patients have lived through many of those. And again, I pulled, again, courtesy of Hallie, this is her slide, a description of some of these, major sociopolitical events, again, that older adults have lived through that we have not. Perhaps. So starting 1920, women's right to vote, the Great Depression. We've got, especially for those who work with VA, different wars, World War II, Korean War, Vietnam War, there's the Cold War. So Civil Rights, the Civil Rights Act, Stonewall Riot, Sexual Revolution, Don't Ask, Don't Tell, gay marriage, 9/11 attacks, the Me Too movement, also sort of technology has changed. So let's, when I'm working with a patient in my office, I want to be mindful, and I want to remember that they come in with a wealth of experience, and hopefully as that sort of approach can help all of us, including our teaching and trainees, have a more sort of person-focused and kind of combat that sort of concern for ageism. All right, so that's what we can do on an individual basis, or my suggestions for things we can do on an individual basis for people around us. I'm going to talk about quickly the pipeline, ways to try to help training. This was a study published in 2021 in academic psychiatry. It was simply, not simply, it was actually, more than simply, but it was a survey of general adult psychiatry program directors, and the aim of the study was to identify factors that may influence residents' preferred geriatric psychiatry subspecialty training. 24% response rate of the programs, and out of all the variables that were asked about, only one independent variable was associated with the percent of residents that became geriatric psychiatry fellows, and that was the number of geriatric psychiatrists at the resident's home institution. The authors postulated that geriatric psychiatrists can act as ambassadors to promote the field and serve as mentors. You have more faculty, there are more opportunities to have positive clinical interactions with as well as other educational experiences such as didactics, journal clubs, and clinical case conferences. Maybe geriatric psychiatry faculty, if there are more of them, they can influence curriculum development and rotation planning. So at least call for, myself and some of my colleagues in geriatric psychiatry, that call is we can, be more involved in, residency programs, raise our positioning, our visibility, and engage with residents so that they can see what geriatric psychiatry is and what we do, and sort of the positive and intellectually just interesting, but also the rewarding aspects of what we do. So I do count that as I'm thankful for my colleagues, and that I do have a number of good colleagues here, and that perhaps this could be something I extrapolated for, many programs don't have a lot of geriatric psychiatrists. How do we as programs kind of collaborate to try to leverage our educational influence through maybe collaboration with other programs so that residents overall can see what we do. Also, here was an interesting study was so highlighted to me regarding a pipeline for medical providers who work with patients with dementia specifically. In this study, interviews were made of 27 physicians and nurses. They were just 2 years out of training, so fresh graduates, and why they did or did not decide to go into a field where they focus on patients who had dementia. So the themes for those who ended up preferring working with patients with dementia included rewards of making a difference. They felt like this was a rewarding field. They really appreciate that this is a different type of care. And they felt like that working with dementia patients or patients' dementia really aligned with their personal characteristics. So what I found interesting is that for those who elected not to work with patients with dementia as sort of a focus, they also wanted to have to make a difference and wanted to have notice those rewards of making a difference, but they felt that working in this population was too challenging, and that high level of challenge made it seem like they couldn't. They didn't feel like they were making a difference. Whereas those who wanted to work with dementia, they actually considered that challenge as positive, meaning if they overcame the challenge, they made even more of a difference. It's even more rewarding. So I feel like that was an interesting mindset, and I feel a lot of us probably relate to that. But it was nice to have that articulated in some research. Okay. I also want to mention. So I talked about so smoking use as an individual, just a little bit of tidbits there on the pipeline. What about the fact that regardless of what we do, there's just never going to be enough geriatric psychiatrists? So how do we leverage expertise through innovative care and educational models? And this just lists some examples. Collaborative care is something that is a growing model of care in psychiatry, where psychiatry places psychiatric consultants and nurse managers and primary care clinics, at least in this model, to help improve screening and access of primary care patients to mental health care. So it's a way to have one psychiatrist be able to supervise and manage and consult a larger group of people and still provide decent mental health care, even if it is through sort of a consultation or supervision type of model. Out of Harvard Review or in this community is Pearl's program to encourage active rewarding lives. I want to call out my colleague Mark Snowden in innovating this more community-based program to get depression treatment out into the homes or out into the community through collaboration and training of some of our social services colleagues. Telemental health, of course, a big deal, especially with COVID, where I'm personally finding myself reaching people in areas I never reached before because of the ability to access that through technology. Shout out to Kate, Project Echo, and this model of training, case-based training, and support for our colleagues out out in primary care settings, but also in career in the VA, we have a Project Echo, and there's also Project Echo initiatives focused on psychiatry from other institutions as well. It's a really great model to try to get our expertise out there to the people who are on the ground as private care docs or other psychiatrists or other providers in a case-based format. Finally, I want to make sure we have enough time for Q&A, so I just have a couple more slides. So I talked about things that we can do, the pipeline, some innovative models, especially some that are many that are happening out in our own home institution. This is not the issue of not having enough mental health providers is a big deal from a policy standpoint, from a public standpoint, and is recognized at a national level. So here are just some sort of guidelines, initiatives, calls for action that have been published for your reference. For example, the Institute of Medicine 2012, or the Institute of Medicine 2012, the Mental Health and Substance Use Workforce for Older Adults, in whose hands publication is available online, and is Institute of Medicine sort of call to action and sort of ideas for how to improve the mental health and substance use workforce for older adults. SAMHSA 2019, older adults living with serious mental illness, the state of the behavioral health workforce. I actually cited some of their listings of food and mental health workforce in my earlier slides. Alzheimer's Association and Centers for Disease Control Prevention, state and local public health partnerships to address dementia. There's the 2018-2023 roadmap. It's another great publication. And then I'm going to highlight a little bit the 2016 Washington State Plan to address Alzheimer's disease and other dementias, because this is happening locally, and I believe many of you are maybe directly involved. So real quick, that last, let me go back here. So that Washington State Plan to address Alzheimer's disease and other dementias, part of that included a number of sort of ideas, guidelines, initiatives, to get, or recommendations for initiatives. I decided to pull out 3 that I felt were specific to mental health. And one of the descriptions was to develop a dementia capable, culturally competent primary care workforce. I felt like, how do I put this? If we develop a dementia capable, culturally competent primary care workforce, that's really going to be helpful for everyone, both mental health wise, and even though the psychiatrists might not be directly involved, it's still mental health related, dementia related priority. They also expressed a priority to improve understanding of response to challenging and or complex behaviors. This could improve, I think I recall correctly that this involved creating a network of trainers or resources to help health providers effectively respond to individuals with challenging behaviors. So kind of education or network of training. And third item was to strengthen numbers and effectiveness of long-term supports and services workers. So enhancing training for them. And in fact, I believe that this has been implemented and rolled out, especially training programs for long-term care support and services workers. So I am wanting lots of time to discuss. So here are my take-home points for you. The geriatric mental health workforce consists of a variety of many disciplines. That was our first section. Using geriatric psychiatry to direct care workers examples, we can conclude the current workforce is inadequate to meet growing need, but we can help this need by addressing ageism, elevating the field of geriatrics, leveraging our own expertise, and supporting public health initiatives. Okay, I'm reminded to give you a QR code for an eval, so there you go. And we have about 5. I actually don't know when I was supposed to end. I have time for Q&A or discussion for the next few minutes, however long we have.
We have until 9 if we need it. And yeah, great. If anyone has any questions or comments, feel free to unmute or toss them in the chat. But thank you so much.
Lucy, this is May. I have a question. And maybe I don't think you alluded to this, but in geriatric medicine, at least there is some recognition that you need more time per visit, and I think we've come a long way on that. Is that appreciated in neuropsychiatry as well? Is there like a provision for that in your visit, or do you just do time-based, or how does it work just to make it viable?
Yeah, no, the viability is a challenge. I don't know that specifically, and I might need to consult to give you accurate information. I might need to consult some of my colleagues who do bill. I think I come from a disadvantage because I do work in a system where I don't bill directly and I don't have to deal with Medicare directly. So I don't have to be as aware of some of the disincentives or incentives. We do, I hate to say this way, I'm going to just go ahead and say I don't know the answer to that. My worry is, my guess is maybe not, but they did change coding a bit not too long ago to try to accommodate more complexity, more time. So perhaps that sort of general sort of coding has been able to capture some of the complexity that we can bill extra for older adults. Okay, so yes, the VA does have some protections of time, but that is starting to change with regarding new national guidance about utilization and visit length. Okay. I mean, personally, my own practice, in the mental health clinic, that has not, I don't have more time or more, I don't have by definition longer appointment times, although they do get, the oversight of my clinic is not so strict where I can, for individual cases, request a longer appointment for certain patients. It's not sort of built in. My clinic grids personally look a lot like some of those my colleagues who do not have older adults, which we all know working with elders, it takes more time. It takes more time to get them to and from the waiting area. The documentation is longer. Some of the chart reviews are longer. So I think, in a sense, perhaps we are in this area doing more work for the same amount of, I guess, pay or time. Yeah, it's been noticed that many providers clinics are limiting Medicare or only accepting certain Medicare supplements. Yeah. I'm guessing you're speaking to sort of primary care or some specialty clinics. I do feel like in psychiatry we are a little bit more of the canary in the gold mine to some extent. Medicare, yeah, it's very hard to find a mental health provider through Medicare because a lot of psychiatrists have the luxury of not needing to. They can have patients come private pay, or they can choose to work with primarily younger adults and not older adults, and still have a very, very busy, viable practice. So it's been a long time a challenge to find a mental health provider through Medicare. Yeah. I also think about in terms of recruitment. Again, this is something that you know well and can speak to, which is people who go into these subspecialties don't necessarily have a higher salary as a result at the end. With growing debt burden and sort of other just life priorities, it's getting harder and harder to entice or kind of help. It's more of a, it's almost more of it's a barrier or a sacrifice to try to do another year of training financially. And so that's been a challenge for the fellowship programs, not just for geriatric psychiatry, but all the psychiatry fellowships in general. That the numbers of people entering those fellowship programs have been going down year by year, including addictions, which you would think would be pretty popular considering the high level of needs, but those numbers are going down as well. So psychiatry, we are actively discussing this problem and trying to figure out better ways to do that.
I was wondering, with the consult liaison fellowship, that came later on in the game, I was just wondering kind of how that's impacted geriatric psychiatry, if you can comment on that.
Yeah. A lot of us have talked about and believe that when consult psychiatry became a recognized subspecialty, that drew a lot of people out of geriatrics. Excuse me. So a lot of us believe that. I'll confess I wasn't around when that happened, so I actually didn't experience firsthand the number, what it was like for the numbers to drop. But a lot of us do think about that. So that is an extra challenge for me and in geriatric psychiatry, is helping people understand that there is a difference between consults and us, like that people who are interested in that medical med psych interface, the complexity, that yes, that will draw people to consults, or for geriatric psychiatry. But I do feel like consults, they're a little bit more acute care focused, they're a little bit more hospital-based focused. In geriatric psychiatry, we span everything. We can work in long-term care as consult providers in hospitals, but also in outpatient clinics and primary care clinics, sort of consultation. So we can, I like to say that we can do everything. And yes, we do tend to focus specifically on older adults. So yes, I also highlight the fact that we have an affinity working with older adults as well that draws us to this field. And thank you for everyone for coming. I've seen the thank yous in the chat.
Yes, thank you so much. We greatly appreciate you giving this talk to us, and we greatly appreciate you and the royal you of your specialty and all that you do for older adults and all the partnership. We are so lucky to have a lot of geriatric psychiatrists around us here, and I'm always grateful for that and in all of the different settings. So thank you for what you do, and thank you for this talk.
You're very welcome. Happy to be here. And thank you also. I really love collaborating with all of you. So thank you. So maybe should I stop sharing? I'll stop sharing. Okay.